When your organization rolled out virtual care, what are some of the technical challenges that cause frustration for both patients and staff?
Yeah, so that's a great question. And you're really getting at the heart of change adaptiveness in healthcare. When we look at platforms of deployments like virtual care, we kind of use the old people, process, and technology approach, right? The technology is pretty cool and pretty sound, and we know about the people, but I think the process piece is due for an upgrade, due for some modernization. And I think this is the biggest barrier that I've seen with these technology deployments.
I mean, I actually disagree a little bit that people is not the problem. I think people is a big part of the problem because we don't have enough people. That it's like hard to even fathom taking a whole team and pulling them away and having them just do the virtual care work because we're trying to keep up with just taking care of the patients who are like physically coming through the doors. And so like it's a people problem.
When I was practicing full-time as emergency medicine and then I led a department through all of COVID, I was like, oh, technology will fix all this stuff. Why don't we just put the technology in? Now that I'm in the role that I'm in, I realize that really the people in the process are actually much harder challenges than the technology. What I do think we owe the end users, though, is a really mindful approach to UI UX, right? If we're not delivering a user experience that's at least equivalent, ideally better than what they're experiencing today, then we fail.
Welcome to Beyond the Blueprint. My name is Greg Malkery. I'm the Managing Director at Spyglass Consulting, and I'll be hosting today's panel discussion on deploying virtual care programs at scale. This episode today is part of our collaboration with AMDIS, the Association of Medical Directors of Information Systems. To help us dig into this, I've invited three healthcare leaders who've been on the forefront of virtual care. We have Dr. Evie Cunningham, the Chief Medical Officer at Cadence RPM. We have Dr. Mark Pierce, the former CMIO at Parkview Health in Fort Wayne, Indiana. And finally, we have Dr. David Wong, the Director of Virtual Healthcare Product Management at Memorial Hermann Health System in Houston, Texas. Find out how healthcare leaders can navigate this landscape when we go beyond the blueprint. A 2024 report from the Chartis Group found that 80% of health systems offer virtual care, but fewer than 30% say they're doing it well. Failure has real consequences: dangerous delays in care, rising clinician burnout, and widening healthcare disparities. Today, we're going to explore three key questions. What does a successful virtual care program look like in practice? What major roadblocks are preventing large-scale deployments? And how can healthcare leaders make virtual care a reality for everyone, regardless of where they live? So with that, why don't we begin? And Evie, we're going to start with you, if that's okay. Evie, can you share a story from your time at Providence Health where virtual care saved a patient's life or made a big difference in their outcomes? And perhaps what some of those key insights are from a leadership or a teamwork perspective that helped contributed to the team's success?
Yeah, I mean, I think a lot of us cut our teeth during the COVID era. So we were actually, I mean, everybody had been talking about virtual care, I think up to COVID. There had been like these small little innovations that were happening in different places across the industry and different healthcare systems, but none of them had really scaled. And I think the first time we really had the experience of scaling virtual was, catapulting ourselves into what happened during the pandemic. And we launched a COVID home monitoring program at Providence. I wasn't the CMIO, by the way. I was actually the chief of virtual care and digital health, so I don't want to take credit for being the CMIO, but I led a large portfolio of telehealth programs, remote patient monitoring, hospital at home, and we launched the COVID home monitoring program, had over 30,000 patients being monitored over that time and saved countless lives. That was when we really realized that remote patient monitoring or remote patient care was actually a thing. Like you could actually manage patients this way, and it might even be a better way of managing patients because you're not making them come into the hospital or the clinic unnecessarily. The thing is that all of that collapsed and collapsed down once the pandemic started to wind down, because nobody could really figure out how to operationalize it in a way that it was sustainable financially. So once the money dried out, then the funding dried out. And so a lot of these programs sort of collapsed. And that's really where Cadence, that's where I met, when I met the leadership at Cadence, and really started thinking about how do we scale this capability in a way that's financially sustainable by doing it with a partner who has better technology and a better operating model to run really efficiently, be able to successfully bill in a fee-for-service environment, which is really hard to do, and do it in a way where we can do it in partnership. Because I think partnership is really critical. And one of the things that I've seen now, when we talk about saving lives, being over here on the other side with Cadence, where we're now scaled across multiple health systems. We have over 50,000 patients that we're monitoring every day. And we pick up, there's these unintended consequences of, like, positive unintended consequences of remote patient monitoring that we don't think about. Like, yes, we're better managing hypertension, we're better managing diabetes, but we're also picking it because we're checking vitals on patients and we're talking to these patients almost every day, every other day. We're picking up atrial fibrillation, heart block, a patient who's decompensating into sepsis, like countless lives that we're saving and things that we're picking up that we didn't even realize we would be picking up in these types of programs. So that's a testament to sort of our journey at Providence and some of the things that I've seen here on the other side at Cadence.
Great. Mark and David, what important lessons should healthcare leaders learn or take away from every story at Providence Health? What would you guys like to contribute here?
Yeah, I'd throw in that I think the real challenge is take apart and peel apart a little bit about what happened in the pandemic. And there's a lot of issue around funding and sustainability of these programs. And I think one of the key aspects of this is there's work to do on sort of both sides. The funding piece obviously needs to be worked out. And my goodness, the last, 14 months, sort of the political changes, and I'm not sure how you bank on a funding source at this point. But while that's settling, while that's dust settling, I think it's really smart for organizations to sit down and peel apart what worked well and what didn't work well, because the time to scale these, if it isn't here, it's darn close. And this is going to need to be an integral part of healthcare delivery as we go into the future.
Yeah.
And what about you, David?
I would say that from my perspective and what's resonated with our system leaders is to really have a really good articulated communication around return on investment, right? So not all use cases of virtual are value creative. Sometimes it's actually value destructive. And I don't know that everyone always pays attention to which is which, and to at least make sure that you've done your due diligence to have a thesis going in as to whether you're creating value or are you actually potentially destroying value. I think being mindful of that has been very helpful. And then also articulating like what our thoughts are in terms of a financial model or pro forma has been very effective in persuading our leaders.
Dave, you want to maybe go to another level of detail about what models are providing a compelling ROI, or some of the business modeling exercises that your team worked on at Hermann Memorial?
Yeah, so, for example, one of the exercises we've done recently is really looking at mapping out our geography of our catchment area, where we're getting patients. And when you take a deep dive, we're actually getting more patients, or we're seeing more patients virtually in areas that we don't have a good brick and mortar footprint. So then the question arises, is this a good sort of patient acquisition strategy for alignment with our system, where we don't have to do an asset heavy approach where we're building brick and mortar facilities to get to a new market and find out, hey, can we have a presence here, attract patients, and get new customers for our platform? And that's really resonated, because that sort of deep dive is what our leaders really appreciate, rather than just sort of like, oh, we just want to do virtual. We want to do thoughtful virtual, strategic virtual. I think that's really been a helpful messaging for us.
So, I would say, yeah, go on, Mark.
I was going to say, I would chime in. I think there's a critical nugget in there, and that is to first fall in love with the problem and then understand if virtual is the answer. And what I've seen work in some unique spots where it's been effective in my prior organization was two different models, right? So one approach was this virtual specialist model where we were trying to keep some patients local at more remote hospitals closer to family members and loved ones, and yet still receive top-notch care, right? So this is an internal referral model, provider to provider, yet it's been beneficial, especially if there's a subspecialty problem where it really just needs a treatment plan, and that subspecialist doesn't need to be present every day to execute that plan. And that's been very effective. And the second piece that sort of dovetails off of both what David and Evie have said is we have sort of a home monitoring program for post CHF discharges to try and keep them healthy and from readmission, combining sort of the low tech Bluetooth scales and whatnot with some of the high touch of a virtual visit. And these started with problems, not started with the solution. And I think that's a key angle to view longevity in virtual care from.
Yeah,
Awesome.
I just want to piggyback on the at Providence. One of the things that we did specifically was, to David's point and to Mark's point, was be very strategic about the types of programs that we would bring to scale. And we did exactly that with teleneurology, telepsychiatry, where we know we don't have enough telepsychiatrists. We know we don't have enough neurologists. So, before I left, we had a 7-state, 90+ hospital teleneurology program where we could staff it with 3 neurologists covering 90 hospitals. And 70% of the time, we could keep the patients in the community hospitals and not have to transport them to the big hospital where we were underbedded. So in a lot of health systems, these big telehealth inpatient services are really designed around bed capacity and optimizing the patients to stay in their communities as much as they can and empower those boots on the ground workforce to upskill and provide the care that they need in these community hospitals or critical access hospitals.
Great. All right, let's shift to segment 2. Let's talk about a little bit more about pulling the thread of what's holding us back. Mark, I'd like to start with you. When your organization rolled out virtual care, what are some of the technical challenges that caused frustration for both patients and staff, and how did you overcome these issues?
Yeah, so that's a great question, and you're really getting at the heart of change adaptiveness in healthcare. Here's sort of my take, right? Traditionally, healthcare is viewed as change averse. So any new tech that comes in, there's sort of a no way attitude. And this view goes all the way back to meaningful use, high tech, and even before that, right? But in terms of having technical barriers really be the main barrier, I'm not sure I'm even ready to go there yet. Here's what I mean by that, right? I think these technologies, Greg, would be much more welcomed if they were designed and implemented in a way that makes sense and fits. And so what do I mean by fit? When we look at platforms of deployments like virtual care, we kind of use the old people, process, and technology approach, right? The technology is pretty cool and pretty sound, and we know about the people, but I think the process piece is due for an upgrade, due for some modernization. And I think this is the biggest barrier that I've seen with these technology deployments. We think about workflow as a widget assembly line. And I think these are really knowledge platforms. So in a sense, the technical barriers are thought flow barriers. And I think that's probably the formidable piece that we're up against right now, because these need to fit to the way we think about and organize care. And they need to feel not so separate from how we provide care today. And I think that's better said in a different way. It's a cognitive fit issue. And I wonder out loud if that's often perceived as being tech averse or too comfortable or politically entrenched and things like that. And I think in terms of our own healthcare deployments, I think when we get our arms around thought flow and how these systems really interact with how we think about the work between our ears, I think we're going to really see a lot of these barriers to adoption go down.
Wow. Well, and Evie, your program is pretty large. Did you come across a lot of these issues dealing with older systems and processes and how they actually fit into virtual care? Was this an issue for you guys?
Yeah, I actually disagree a little bit that people is not the problem. I think people is a big part of the problem because we don't have enough people. Like, we don't have enough clinicians as it is in the health system trying to take care of the patients in the brick and mortar facilities, that it's like hard to even fathom carving off a piece of them or taking a whole team and pulling them away and having them just do the virtual care work, because we're trying to keep up with just taking care of the patients who are like physically coming through the doors. And so like, it's a people problem. It is a process problem in the sense that there's not the way that we do the work today and the way that we need to be able to do the work in order for it to be scalable in a virtual care environment or a virtual care like reimagined sort of care delivery model is different. So all of the yes, you need to understand the way that the work is being done, and you need to be able to plug into the workflows, and you need to be able to integrate, which is really, really hard. But you also need to, in order to run it efficiently, the current legacy systems and the current legacy ways we pay clinicians or we pay caregivers, the way that we have work design, the staffing models, all of that is it needs to change in order to be able to do it in this other type of model. And so you're dealing with incumbents and legacy ways of doing things that's very hard to break apart and put back together in a scalable way. And then from a technology perspective, I would agree there's a ton of amazing technology out there. Before we selected our RPM vendor at Providence, which ended up being Cadence, we looked at so many different RPM platforms. There were amazing technologies, amazing platforms, amazing wearables and gadgets and doodads and AI. And the problem is that none of it integrated into the EMR in a meaningful way. So it was fragmented and siphoned off, and you were going to have providers go in and out of different systems, and they aren't going to be able to do that. And so it's really important to find that integrates, that supports the ability to deliver care and provide the care in a different way from an operating model perspective and a logistics perspective. And also, I think if you don't have enough workforce, you have to think about how you extend your workforce with other types of innovative partnerships and innovative models.
Wow, great insight. David, let me pull on a different thread from you on a similar topic. Just about from a culture perspective, how do you guide teams from doubt to fully supporting virtual care? Is everybody on board, or is it kind of fragmented? Some people more gravitating toward this model of care?
So I would say you obviously have your early adopters and then you have your late adopters. I think the path to success is to partner with your early adopters and then also really listen to them and the feedback and iterate your approach as you sort of pilot and then go to scale. I think, when I was practicing full time as emergency medicine and then I led a department through all of COVID, I was like, oh, technology will fix all this stuff. Why don't we just put the technology in? Now that I'm in the role that I'm in, I realize that really the people in the process are actually much harder challenges than the technology. What I do think we owe the end users, though, is a really mindful approach to UI UX, right? If we're not delivering a user experience that's at least equivalent, ideally better than what they're experiencing today, then we failed. So we recently sort of redid our device strategy and our device logistics, and we had to update our security, but we were very mindful that the new process was actually easier than the old process. And then, we listened to our stakeholders, made sure that we weren't adding steps rather than removing them. And then we got lots of great feedback afterwards, like, oh my gosh, this is so simple. I can't believe how easy it is. And that's really sort of my North Star is that's the result we should get, is that your end user should be like, wow, that was really easy. And that's probably something that Silicon Valley does really well to make sure that they get customer adoption that we probably need to think harder about.
What about Evie or Mark? What have you found in your organizations in terms of adoption? Are docs jumping up and down? Did they see it as a hassle? Does it tend to be younger docs who gravitate toward the use of virtual care? What are you finding in terms of cultural adoption of these technologies at your respective organizations?
Do you want to go first, Mark?
Sure. Yeah, I'll jump in. It's a solid, it depends. And I'm going to go back. I'm going to go back and say it depends on the problem, right? If we have a small subspecialty group that is stretched and they have 11 community hospitals to cover, they welcome this type of technology. And I think, what Evie and I were saying isn't really too different. The technology has to be adopted first. And I believe one of the whole purposes of virtual care is in part a solution to the workforce problem. We don't have enough bodies who are trained in the healthcare workforce. How do you fix that? Well, you leverage a one-to-many through technology like virtual care. And so I think when that problem is staring you in the face every morning and you wake up and think, I'm going to burn 90 minutes traveling to a remote hospital today, those are the types of folks that are first in line saying, well, I might give this a try. Before we even get to that point, as David mentioned, it's incumbent on us to make sure that these systems are, that was easy systems, not clunky ones that are markedly different from our EMR, markedly different from a workflow, thought flow standpoint.
Yeah, and just piggybacking on that, we need to be obsessed with, I'm user-centered design obsessed. clinician-centered design obsessed, you are not going to get clinicians to adopt anything unless it's super easy, straightforward for them to integrate it into their workflow. I mean, you find the occasional doc who's like, I heart innovation, I'll try anything. Those are really good ones to test out a proof of concept. But if you want to get to scale, I would say there's like 3 different categories of docs that I encounter. There's the like, yes, I'll try something. I'm willing. It's 30 to 40% of the time you'll get the like, yeah, if my medical director or whatever, my leadership tells me I need to do this and we're going to move forward, I'll go along with it. Then there's that 30 to 40% that's like hesitant. They might be overstretched, overtaxed. Like you can get them across the finish line, but you really got to help them understand the clinical value, what it means to them, how it might help ease the way for them, and also give them the time to like go through the training, education process, because they're not going to want to do it just like on the fly, or train themselves to do it. And then there's that 20% that's like, hell no. I mean, and those are the ones that the hell no doctors, it's just like, you probably just want to leave them alone because it's gonna, I mean, you eventually, if everybody's got to get on board, you're going to have to take the time. But think about the time when we like transitioned over the EMR. I actually think there were more hell no doctors during that time. I think, yes, to your point, Greg, the younger ones, they're more digital natives. They seem to be more attuned and willing to try this stuff out. But there's a lot of more senior docs too, willing to jump on board and try stuff too. So I've seen it all across the board.
David, from your perspective, where does leadership and governance fit in as it relates to deploying these programs at scale? I guess some of the health systems I'm working with in Bakersfield, right? A lot of the health systems are expanding to these rural areas. Now, how do we coordinate those resources, right? Where we may not have the ideal person there, but how do you coordinate that back with the mothership?
That's a good question that I'm trying to answer now. So I don't know if I can answer it today. I think I have some thoughts as to how we do it. I might defer to my colleagues on this call as to their experience. I think there's a big debate in our system about whether or not you centralize resources versus you diversify the footprint or you even keep them local. I don't know that we've landed on the right answer. We spend a lot of time visiting other health systems as to what to do. Would actually love to hear from my peers here as to what their thoughts are.
Yeah. So, I mean, for example, at Providence, and actually Dr. Wong and I have had a couple conversations about this. We had a couple different models because there are some things that make a lot of sense to have centralized, organized at the central nerve center of the organization and then scaled across the organization. In those programs, you want the operations, if the P&L is going to be owned by that unit, you probably want them to be leading the charge on the whole operational components and the deployment of the solution, versus there's some things that just make more sense from a local perspective, where it might be sort of a local program or a local support system within 2 small entities, 2 clinics, a couple of clinics that are sharing resources. And in those cases, you probably don't need a centralized model, but you need some best practice capabilities to support sort of some standardization of how you do this, especially when you're thinking about how you get reimbursed for it, care pathways, and things like that. And you want a playbook that you can reuse in different places. And then there's some programs where it's a shared model. So for example, at Providence, we had Cadence and Providence remote patient monitoring. We deployed it within the Providence Clinical Network, which was all the clinics. And so we were in partnership. So part of it, my team owned some of like the program management, figuring out how to do all the diligence, the evaluation of the solution, the financial modeling, and then the playbook. But then we deployed it within the clinics. Virtual nursing was another one where it was a shared program, shared operating model. So I think there's a couple different ways you can do it. But I'll also defer to Dr. Pierce if you have any other thoughts.
Yeah, I mean, so you're asking what the cake's going to taste like, and it's sort of in the oven right now, right? Because there's a lot of dust that needs to settle, I think, and a lot has been touched on, right? A lot of it is reimbursement, right? But we haven't even opened up the Pandora's box of equity and rural and all sorts of other digital determinants of health that are out there, right? We haven't even touched on those things. So what I would say is part of the secret sauce early on is understanding the use case and understanding the goal you start with. Again, I'm back to understanding the problem. And we've talked about issues of, where the technology lives, where the governance lives, and it sort of depends, right? I would argue that the direct to patient for CHF that lives in our cardiovascular service line pretty easily. But what about the consultant to consultant inpatient model? That feels different. So here's what I would say to kind of sum it up and go forward. I think we have to earn the right to scale this. And that is fall in love with the problem that has a cleaner ROI financially and from a patient-centric standpoint. And you sort of have to be a cherry picker to find those problems. And that potentially can earn us the right to answer some of those questions, Greg, because we don't have a safety net if we fail. We don't have a safety net financially. We don't have a safety net from patient care standpoint. So I think we have some due diligence and a little bit more time to get through before there's a great best practice as assumed to what worked in my little town.
I don't think that this is a problem that's been well solved, at least to the health systems I've talked to in Bakersfield. Even if they get the funding, even if they construct the facilities, that doesn't mean that there are actually workers there to actually fill those roles. Although HRSA does have a huge amount of money allocated to workforce enablement by getting folks from UCLA Medical School to go out to Bakersfield for 5 years and then forgive their $500,000 loan. Right? So I guess there are strategies, but I think we're still early on. So I don't know necessarily there's actually a definitive solution today. David, let me go back to you. Let's talk about, I love this idea of underserved areas. Many patients face digital divides like poor internet or low technology skills. How do we overcome some of these barriers as it relates to virtual care in serving some of these underserved communities?
I think one is to be just mindful of our technology footprint, and it is to be very considerate of the access to technology. In our research, I don't know that smartphone access is necessarily a big barrier. I think maybe reliable phone internet is a bigger barrier. So, you can approach that a couple different ways. We've tried and are currently trying, sort of centers inside those communities where they can come and do a video visit if needed. Obviously, if we can enable it on their own phone, that improves access on their side. Obviously, as a nonprofit health system, it's part of our mission to serve all in our community. Just to be very mindful of what their access points are and then how do we navigate them. One of the things we've also done is do a lot of sort of shadowing, not only on our clinician operations side, but also to talk to our end customers, which are the patients, and understand what are their barriers that they're encountering, whether it's reliable internet access, reliable cell service, or even language barriers, those types of things.
Great, thanks, David. Evie or Mark, would you like to chime in on this idea of healthcare disparities?
Yes, this is something that I feel very passionately about. It's part of the reason I'm with Cadence. 2/3 of our patients live in rural and underserved areas, and the average age of our patients is 72. So we have learned a lot about what it is that we need to do to be able to meet patients where they are. I like to prophesize the KISS philosophy, keep it simple, stupid, right? When it comes to our devices, they're cell enabled, because I learned very early on that elderly patients or patients in rural and underserved areas, they struggle with Bluetooth. They may not have Wi-Fi. So cell enabled devices configured to identity, literally a one button click and you're connected and it knows who you are. We do most of our communication with patients via text message, SMS, and phone calls. We don't do video. We're going to be doing some video in some future use cases, but it's not required. You can deliver this kind of care without having to do video visits with the patients. You can still make a clinical impact, significant clinical impact, and reduce costs and reduce admissions as a result of that. And then again, we do a lot of research on our patient population. So we're looking at developing a patient companion app. I hate to use the word app because I know not all patients want to download an app, but how do we do it in a way that it's going to be sticky for them, that it's easy for them to do authentication? I don't know, but for those of you on the call, you've probably experienced the army of people that you have to do password management in the early days of having apps at health systems, because patients just struggle with that. So trying to like reduce that friction and make the things accessible yet also secure and private and compliant is something that I think is really critical if you want to get adoption and use and also meet the patients and meet that digital divide that's really important.
That's well, I would tell you. Mark, what are your thoughts? Do we have an issue right now? It seems like everybody's got a smartphone right now. Is that the least common denominator in terms of being able to connect with the health system?
It's a really good question. And I think for some, the answer is yes. Obviously, much of the country is covered with fairly decent cell service, but not 5G. And as Evie mentioned, sometimes you struggle with video. I think this is a problem to be fully solved. It feels like for the majority of Americans, the mobile cell phone is the least common denominator. But the real question that needs to be asked, and I think we sort of know the answer is, for those who are in most need of these services, is that the least common denominator? And I think the answer is yes, in part. So probably the only thing that I would add is, gosh, is there an opportunity to leverage other trusted community partners, clinics, shelters, churches, barbershops, whatever, as another access point to help expand coverage to those who really need it? Again, a real big issue to be solved, but I think if you're doing the 80-20 rule, you do land on the cell phone as the least common denominator.
Those great comments. All right, we're at the end of our time, but I did promise you guys I had a little surprise. So I got 5 minutes left. I'd like to end with something a little bit different in a final lightning round. I'd like to invite one of our panelists to have the opportunity to ask a quick question of the other two. So keep your answers brief. And who would like to kick us off? Anything?
Evie, this was your idea, so I'm looking at you.
Okay.
Mark, I have a question for you.
Should have said nothing.
Where do you see now with all this experience we've been talking about virtual? Nobody's been talking about AI in this conversation. Where do you see AI going with respect to the virtual digital? Like, how can we integrate it into these care delivery models, and how could it even amplify our reach?
Yeah, so I think it's a legal requirement now that every conversation around healthcare has to touch AI since it's the center of the bingo card. So let me jump at this, and I'm going to say something that I hope is provocative that maybe one of you will say, absolutely not, you're wrong, and let's see where we end up, right? So we've talked, the three of us have touched on how this integrates into how we provide care. Does it integrate with the EMR? Is it a different workflow? I'm hooked on, is it a different thought flow and cognitive fit? That's sort of my shtick and where I like to spend a lot of time. My question for both of you and my answer to that is, gosh, is AI, as we see it now with ambient and some of the other technologies that are getting some traction, is this the first step to the post-EHR era? And by post-EHR, I'm talking about removing that UI between my brain, how I think about things, and providing care and using the knowledge that we've spent most of our lives to do and to take care of patients, right? So in my butterflies and unicorns world, we are one step down the road of eliminating that major friction point of having a different thought flow, scene flow, clinician-centered UI disappear. And I think if AI to some extent can help us with that, I think that opens up a ton of other opportunities for alternative models like virtual care. And I think it will give time back to what we really want to do and help with a lot of the issues that are out there. So agree or disagree, that's what my hope for AI is in terms of virtual care.
Well, Dave, what do you think? Any thoughts?
Yeah. Oh, sorry, response or a separate question?
I think this is a great topic, and purposely didn't bring AI in because I thought it was a little too on the edge, but I like the way Mark framed that. Any thoughts here? Feel free to pontificate. It doesn't have to be a reality today, but you could be forward thinking.
Yeah, I mean, we launched one of those AI auto-scribe platforms in our system, and it was amazingly well received. I mean, I helped facilitate that a couple of years ago, and I regularly still get texts from primary care doctors saying like, "You've changed my life," and that just really fills my cup in terms of like my why of like why I do this work. I think the goal, right, is to actually, alongside the EMR meaningful use, and I put that in big air quotes because I think any clinician is like, really, was this meaningful use? Is that AI hopefully will actually realize that promise, which is it's supposed to be meaningful, right? It should not get in my way. It should not be another encumbrance. It should actually enable the care I want to deliver and make it all easier, right? Whether it's extracting data from the EMR so it's surfacing it up ahead of me, so before I see the patient, or ideally when I need to see the patient, right? I think the way that we deliver care now doesn't make a whole lot of logical sense. And I think hopefully AI will enable a much more thoughtful, reasonable, logical approach to how we deliver care.
Excellent. Evie, I know you asked the question, but I'd love to get your forward-thinking thoughts of where this could be.
Well, a year and a half ago, I spoke at an AI conference and I said that my goal is that in the next 3 to 5 years, when I walk into an exam room to see a patient, there won't be a keyboard. So I still envision that future, and I definitely think that that is the direction of travel of where we're going. I will say this, now being on the tech-enabled services side where I'm in a company that can build stuff, it's mind-blowing. We can build stuff in 3 weeks that takes 9 months to build in a health system just because we can just move so quickly. It's not just people are like, oh, it's an AI platform. Well, it's not, that's going to solve everything. It's actually much harder than that because it's the people, the processes, the technology that weaves into the people and processes. And it's little bits and pieces of AI tooling that you're layering in or AI use cases that you're layering in to gain efficiencies in all these different places across a technology platform, whether it's an EMR or whether it's a remote patient care platform. It's hard work. It's roll up your sleeves. It's doing human-centered design, and it's figuring out where you're going to put these technologies in. So for example, we have a power dialer system to do the outreach to the patients. So we're minimizing the amount of time that we're calling, waiting for the phone to ring, talking to answering machines. Like we're integrating in different use cases and different places to create efficiencies across all the different types of caregivers. We have a proactive medication titration algorithm that we implemented so that now we can do 4 times as many titrations as we did with the same workforce. Like those are the types of things that you're going to have to do. And it's not just like all of a sudden we have this technology and now it's all going to make everything more efficient. It's very hard work because it's use case by use case and capability by capability and caregiver or role by role as to where you're going to be able to layer in those things. But the promise is there because we're seeing the efficiencies that we're gaining by layering in these capabilities over time.
Great. Guys, this has been awesome today. Unfortunately, we ran out of time. So today's conversation made one thing clear. Virtual care isn't an option. I think it's a necessity. It's how we're going to close access gaps, reduce clinician burnout, and deliver equitable care to every patient. Healthcare leaders need to act now. A shift in culture, secure funding, build clinician trust, and to tackle health equity head on. And this is how we make virtual care work at scale. So huge thanks to Evie, David, and Mark. And thank you to our audience for tuning in to Beyond the Blueprint. We appreciate your time and hope you'll join us for our next episode. Thank you.
Thank you.
Thank you for listening to Beyond the Blueprint. Together, we're exploring how thoughtful design can simplify complexity, enhance patient care, and create meaningful change. If you found value in today's episode, make sure to subscribe and leave a review in order to help us continue the conversation. Let's reimagine healthcare together on Beyond the Blueprint.